Hi everyone, my name is Shauna Nunes. I'm a recent graduate from Temple University School of Pharmacy. I have worked at community Walgreens pharmacy for about 4 years, and I'm excited to continue my learning experience here at Walgreens and continue as a pharmacist. So I just want to thank everyone so much again for joining our webinar today. We'll be discussing transplant medications and the role Walgreens specialty plays with helping our patients. I hope through this presentation we are able to answer any questions you may have regarding your post-transplant care. So a few of our objectives today for our presentation is to help you all identify different medications that you are using in post-transplant patients. We want you to understand the specific implications for post-transplant medications and the role they play in your drug therapy regimen. And lastly, we want you to understand the role specialty pharmacies have with helping in therapy management. So here is just a little timeline we wanted to show, starting at the bottom. In the 1960s, or starting in 1954 is when the first kidney transplant was successful. This was the first ever human organ to be transplanted. By the late 1960s, liver, heart, and pancreas transplants were successfully performed, while lung and intestinal organ transplants didn't begin until the late 1980s. Until the 1980s, the potential for organ rejections were limited because of the number of transplants performed. Medical advances started making its way in the 1980s, as you could see on the top left. In the 1983, cyclosporine was introduced. We will be talking about that medication a little bit later on today in this presentation. So in the 1960s, the only immunosuppressive medication we had to combat rejection were azathioprine and prednisone. So as we talk about the medications later on, you'll see that the mainstay medications were greatly improved throughout history. So a little bit of transplant data. Currently, there are more than 110,000 patients in the United States waiting an organ transplant. And then almost 40,000 organ transplants were performed in the US in 2019. This actually set a record for the 7th consecutive year, and this was an increase of 8.1% since 2018. I just wanted to talk about a few types of transplants. So we are going to review autograft, allografts, isograft, and xenograft transplants. So an autograft transplant is a transplant of tissue from one to oneself. This could be an example of a skin graft where they take skin from one part of a person's body and puts it elsewhere on them. An isograft transplant is a transplant of organs or tissues which are transplanted from one donor to a genetically identical recipient. And this is such as an identical twin. Isografts are differentiated from other types of transplants because while they are identical to allografts, which I will talk about in a second, they do not trigger an immune response. Allografts, however, are the most common type of transplants. They are a transplant of organ or tissue between two genetically non-identical members of the same species. So like I said, most human tissue and organ transplants are allografts. And then lastly, a xenograft transplant is a transplant of organ or tissue from one species to another. This is an often most dangerous transplant just because of the increased risk of incompatibility, rejection, and disease that's carried in the tissue. However, with modern medicine, these are quite common and very successful. I just wanted to talk to you a little bit about transplant rejection. So these are just a few examples of the 3 types of rejection that do occur. Hyperacute rejection, it occurs minutes to hours after transplantation, and unfortunately there is no treatment available. However, this rejection is very rare and not often seen. The next one is an acute rejection. This occurs days to months after transplantation, and this occurs when white blood cells attack the new organ that was transplanted because it sees it as foreign. And then lastly, chronic rejection. It occurs months to years after transplantation, and it is most common in lung transplants. Oh, sorry. I also just wanted to talk to you guys a few common signs and symptoms that are associated with transplant rejection. It is very important to remember if you are feeling sick in any way or just feeling like something is wrong, to make sure you alert your transplant team as soon as possible. But some common signs and symptoms you may see are flu-like symptoms, fever, change in weight, swelling, and pain. A few of the most common organ transplants are kidney, liver, heart, lung, pancreas, and intestine. The kidneys are the most commonly transplanted organ. Now I'm going to hand it off to Jamie. She'll introduce herself and start talking about the post-transplant medications.
Hi everyone, I'm Jamie. I recently graduated from Temple Pharmacy School as well, and I've been with Community for the past year. So I'm going to start talking about transplant medications. Typically, after you get an organ transplant, you will start on 8 to 10 new medications that will fall within these categories. These generalized categories are 1, anti-rejection or immunosuppressant agents, 2, infection prophylaxis agents, and as well as supplements. So the first category that I'll go over are anti-rejection or immunosuppressant agents. These agents ultimately suppress your immune system from rejecting an organ. This category can be further divided into induction or maintenance agents. Induction agents are intense immunosuppressants that are given in the initial days after transplantation. So typically they're given about 4 to 7 days post-transplant. On the other hand, there are maintenance medications. These medications prevent the rejection of an organ as well. However, they are lifelong therapies. Maintenance medications consist of about 8 to 10 medications and can be adjusted over time. So briefly, I'll go over induction agents. Specific induction medications are thymoglobulin and Simulect. These medications are both antibodies. However, thymoglobulin is the most common induction agent that we see in practice. This is because it is more potent than Simulect, which ultimately helps further decrease the risk of acute rejection. As you can see, both of these medications are given intravenously, so they are administered in the hospital setting. And again, they are only given for initial therapy. The duration of therapy is about 4 to 7 days for each of these agents. So unlike induction agents, like I said, maintenance medications are lifelong therapies. A patient's regimen will typically follow this algorithm that I've listed on this slide. The 2 classes of medications that are critical components of a patient's regimen are calcineurin inhibitors and anti-proliferative agents. They will typically always be part of a patient's regimen. Other classes of medications can be added on to a patient's regimen based on the patient's risk of organ rejection. Classes of medications that may be added on are mTOR inhibitors, steroids, or T-cell co-stimulatory blockers. So first I'll go over the calcineurin inhibitors. There are 2 calcineurin inhibitors. They are cyclosporine and tacrolimus. Cyclosporine can be called by the brand names Nerol, Gengraf, or Sandamune. This medication, in terms of maintenance medication, is given as an oral solution or capsules. The second calcineurin inhibitor is tacrolimus. It can be called by the brand names Prograf, Astigraf, and Envarsus. Tacrolimus comes in multiple formulations as well. The immediate release formulation is known as Prograf. It is given twice daily, typically 12 hours apart. Whereas Astigraf and Envarsus are the extended release formulations of tacrolimus. And because they're extended release, they're only given once a day and just only once daily. It is important that you take these medications at the same time every day. If the manufacturer of your medication changes, you want to let your transplant team know. And for each of these medications, blood work will need to be taken to ensure that the patient is receiving the correct dose and within an adequate therapeutic range. It is important to know that you shouldn't take your medication immediately before getting your blood work done because this can cause a falsely high reading. So with each of these medications, there are many side effects that can occur. Some of them are kidney toxicity, high blood pressure, and high cholesterol. Also, you can have a deficiency in some electrolytes, such as magnesium or potassium. However, all throughout therapy, your doctor will be monitoring your blood levels of these medications and can adjust them as needed to manage some of the side effects listed above. So going across from left to right, we just discussed the calcineurin inhibitors, and the second class of medications that are a critical component to a patient's regimen are anti-proliferative agents. So the anti-proliferative agents are a class of medications that consists of mycophenolate or azathioprine. Mycophenolate can be known as the brand names Cellcept or Myfortic. These medications are formulated as tablets or capsules, and you can see pictures of them that are shown on the right. Azathioprine is known as the brand name Imuran, and this medication is formulated as a tablet. So you can see all of these medications are oral medications. So like the calcineurin inhibitors, these medications do have some side effects as well. Some side effects are low white blood cell count, low platelet count, and there can be an increased risk of infection. However, this is expected with these medications because we're suppressing the immune system. By suppressing our immune system, our body won't be able to make as many blood cells, and therefore our risk of infection can increase. Another common side effect is GI upset. This is more common with mycophenolate. And lastly, there's a risk for teratogenicity. When a medication is teratogenic, it means that it can disturb the development of a fetus if a woman were to become pregnant. So therefore, if you're a woman and planning to become pregnant, this is something that you'd want to discuss with your doctor so you can plan accordingly. Fortunately, many of these side effects are manageable because the dosing of this medication has some flexibility. So you can adjust your regimen as needed if some of these side effects were to occur. So just to reiterate, we just went over the calcineurin inhibitors and the anti-proliferative agents, which will be part of almost everyone's regimen. And the next few classes of medications that I will go over are only added onto a patient's regimen if a transplant team decides that you need further immunosuppression. So one of these classes of medications that can be added on are mTOR inhibitors. So the mTOR inhibitors are a class of medications that consist of sirolimus and everolimus. Sirolimus is also known as Rapamune, and everolimus is also known as Zortress. They're both formulated as tablets. Specifically, sirolimus comes in a 0.5 milligram and 1 milligram tablets, whereas Zortress comes in 0.25, 0.5, 0.75, and 1 milligram tablets. So the adverse effect profile is similar to some of the medications we previously discussed. They can both cause high cholesterol, low white blood cell count, low platelet count, and can increase the risk of infection. So another class of medications that can be added on to a patient's regimen are steroids. The most common steroid that we see utilized in practice is prednisone. So prednisone comes as a tablet and is dosed based on weight. The adverse effects seen with steroids can either be acute or chronic. Acute side effects are side effects that would occur if you took this medication immediately and within the following days. So some of those acute side effects are sleep disturbances, increase in appetite, and increase in blood glucose. Adverse effects that are chronic are adverse effects that will occur over time. So these adverse effects could be osteoporosis or weakening of your bones, cataracts, obesity, and poor wound healing. However, your doctor will keep you on a low dose of steroid to help prevent and avoid some of these side effects from occurring. So the last medications that can be added onto a patient's regimen is a T-cell co-stimulatory blocker, also known as belatacept. So this is an overall newer medication. It's given intravenously. The dosing is slightly different for initial therapy versus maintenance therapy. However, because this medication is given intravenously, it's less commonly seen in practice. Most patients would prefer to go with the oral formulations that we discussed. So now that we have gone through the immunosuppressant agents, the second category that we'll go over are medications to prevent infection. So like this graphic shows, there's a delicate balance that we're trying to achieve with immunosuppression and infection. We need to have enough immunosuppression to prevent our body from rejecting an organ. However, increasing immunosuppression can put you at greater risk for infection. So to prevent infections from occurring, your doctor may proactively place you on antimicrobial agents. So there are 3 categories of antimicrobial agents that your transplant team may place you on to decrease the risk of infection. They're antibiotics, antivirals, and antifungals. So antibiotics, they prevent the infections pneumocystis pneumonia and toxoplasmosis. Antivirals, we're trying to prevent herpes simplex virus and cytomegalovirus. And antifungals, we're trying to prevent candida and aspergillus infections. It is important to note, though, that most of the time infection prophylaxis is not permanent. Patients will only be on these medications for less than 12 months. So this is different than maintenance medications for immunosuppression. So here I have some specific agents under each of these categories. So the antibiotics that we'll discuss are Bactrim, Dapsone, and atovaquone. Specific antivirals that you may be prescribed are acyclovir and valganciclovir, and antifungals are nystatin, fluconazole, and voriconazole. The first antibiotic we'll discuss is sulfamethoxazole trimethoprim, more commonly known as Bactrim. It prevents the infections pneumocystis pneumonia and toxoplasmosis. Pneumocystis pneumonia is a lung infection, whereas toxoplasmosis is a systemic infection, meaning by systemic I mean that an infection that occurs all throughout the body. So something you want to let your doctor know is if you have a sulfa allergy, because you can't take this medication if you do have that type of allergy. The side effects that can occur from this are allergic reactions, such as hives and rash. So if you were to take this and you were allergic, you would experience that. Photosensitivity is another side effect. So if you were to go out in the sun for an extended period of time, you'd want to put on sunscreen to prevent you from getting burned. And then lastly, crystalluria. Crystalluria just means that crystals would be forming in your urine, and that could ultimately lead to kidney stones. An easy way to prevent this, though, is to drink about 1 glass of water with every dose of Bactrim, because this way the water will flush out your kidneys and prevent the stones from forming. So other options that we can use to treat pneumocystis pneumonia and toxoplasmosis is Dapsone. So if you're allergic to sulfa, you can take Dapsone instead. Side effects from this medication are low white blood cell count, platelet count, and there can be skin reactions as well. Atovaquone is also prophylaxis for pneumocystis pneumonia and toxoplasmosis. And the typical dosing of this is 750 milligrams by mouth every 12 hours. It can also cause nausea, vomiting, and diarrhea. So now we'll discuss the antivirals. The antivirals that we use typically are acyclovir and valganciclovir. Acyclovir is only prophylaxis for the herpes simplex virus, whereas valganciclovir is prophylaxis for the herpes simplex virus and cytomegalovirus. Side effects are pretty similar with these medications. They're nausea, vomiting, dizziness, fatigue. However, acyclovir, we see more kidney toxicity with this medication. So the last category of medications in terms of antimicrobials are, one of them is nystatin. Nystatin is prophylaxis for the fungal infection Candida. And when you have a fungal infection in your mouth, this is also known as thrush. So this is an oral medication. The directions for this would be you would swish and swallow the medication in your mouth, and it would be about 5 milliliters or about 1 teaspoon, and you would do this 4 times a day. I have the side effects listed on the slide. However, we rarely see them in practice, and this is a pretty well-tolerated medication. So lastly, in terms of antifungals, there is fluconazole and voriconazole. They are prophylaxis for systemic fungal infections. Lung transplant recipients are at the highest risk for systemic fungal infections. Side effects from these are liver toxicity, increase in QTc interval. By that, I mean the amount of time it takes for your heart to beat. So it increases the amount of time it takes your heart to beat. And with voriconazole, there's specifically visual disturbances, but your doctor will be monitoring you for all of this. So the last category of medications that you may be placed on are some supplements. The supplements, you're typically given a supplement to prevent something from occurring or to treat a side effect of a medication. Sometimes we do have to add on medications to treat a side effect. So the first one is antacids or anti-ulcer medications. Sometimes patients who receive transplants are higher risk for developing stomach ulcers. So a way to prevent this is to give H2 blocker, also known as famotidine, or what more people are most commonly know is the PPIs or proton pump inhibitors, such as omeprazole, pantoprazole, and lansoprazole. As I said earlier, Tacrolimus and Cyclosporine can cause some electrolyte deficiencies. So your doctor, specifically, it can decrease your magnesium levels. So your doctor may place you on a magnesium supplement to replete those levels and get them back to within a normal range. Also with steroids, I mentioned you can, if you take them in the long term, you can develop osteoporosis. So your doctor may place you on vitamin D to help prevent this. And lastly, they may place you on aspirin 81 milligrams as cardiovascular protection. So this is just a summary slide of everything we just went over. Up top, we have the immunosuppressants. To the bottom left, we have our antimicrobial agents, and to the bottom right, we have our supplements. So it's easy to see how post-transplant a patient can be on 8 to 10 medications. And it's important as a patient to know not only what these medications are being used for, but also to be extremely adherent. Because with those, by knowing what the medications do and being extremely adherent, this increases clinical outcomes for a patient. So now I'm going to hand it off to Sejal, who's going to speak to you about Walgreens Specialty Pharmacy and our transplant services.
Hello, everyone. Thank you, Shauna and Jamie, for an excellent overview. At this time, I'd like to switch gears and tell you how a specialty pharmacy can help make managing your condition easier. Here at Walgreens Specialty Pharmacy, we provide specialized services such as HIV, Hep C, transplant, cystic fibrosis, oncology, chronic inflammatory disease, just to name a few, where our pharmacists and support staff are specially trained to assist patients with their individual needs. Across the country, Walgreens have over 9,000 traditional retail stores. We also have over 300 community-based specialty pharmacies, and more than 100 of these pharmacies are specialized in transplant services. Our specialty pharmacies in communities enable us to develop deeper relationship with our patients and their providers. Our specialty pharmacists are provided additional training and are up to date with the latest treatments and guidelines. And they're also equipped to provide a holistic approach with patients' treatment and assist them with lowering the medication costs. Despite our large national size, we're still able to customize our offerings and provide innovative programs and a dedicated local team. This also enables us to bring local level partnerships, programs, and digital assets to our patients. So you can have a seamless transition to any of our pharmacies that you choose to use across the nation. So just a little bit about our process. For transplant patients' medications, time is of the essence, and our specially trained staff can help get patients the medication they need as soon as possible. When a prescription is received from your doctor, our team initiates benefit verification. If an insurance company requires a prior authorization of the medication, we work with your doctor's office to expedite that process. If a patient's copay is too expensive, then we investigate and connect our patients to financial assistance programs. And finally,
deliver the medication to the location of your choice. We keep the communication line open during this entire process with you and your provider. When the patient has a substantial out-of-pocket expense on their medication, we help lower their out-of-pocket expense by connecting them with a drug manufacturer assistance program or patient assistance groups such as Patient Access Network Foundations and the HealthWell Foundation. We also collaborate with organizations like Help Hope Live, Children's Organ Transplant Association, and National Foundation for Transplant, which helps with fundraising for people with unmet medical and related expenses due to organ transplants. We help patients stay adherent to their therapy by proactively engaging them in a richer, more clinically relevant discussion about disease progression, medication dosing, and their overall health to identify barriers to therapy and the potential side effects. Our clinical staff works with you and your transplant team to resolve any barrier for a successful treatment outcome. Our team is there every step of the way. Many of our community-based specialty pharmacies are located within the health system, and our team will deliver your medication at your bedside. And finally, we continue providing that same care once you are discharged and at home. Walgreens also has a very user-friendly app that helps support adherence by reminding you to take your medications, promote wellness, and offer prescription order status as well. We are also supporting local as well as national transplant groups such as American Society of Transplantation and Donate Life to raise awareness. We're also using our pharmacy resources to raise awareness of organ donation by having the message printed on our prescription pamphlets, as well as on our digital channels. And we have been able to spread the message to over 100 million customers about organ donation. So just to kind of summarize, we have a staff that is dedicated to take the lead on prior authorization to get the medication to the patients as soon as possible. Our staff is skilled in transitioning patients from hospital to home. We also provide proactive communication every step of the way, provide customizable support through Walgreens Connected Care program. And finally, we're committed to helping ease patients' copay costs. So we're here for you from the start, so our patients can get the new start that they deserve. Thank you, and that concludes our presentation.